Welcome. My name is Victoria, and today we are going to be reviewing chronic pancreatitis. So get your jotter and let's prepare for Nclex. Alcoholism is the primary risk factor for chronic pancreatitis. Another major risk factor is malnutrition. In chronic pancreatitis, small ducts of the pancreas, they are blocked by calcified stones. These cause inflammatory processes in which the normal pancreatic tissue becomes destroyed and is replaced by scar tissue. This one is progressive, and then this chronic pancreatitis is also irreversible, and it can result in pancreatic insufficiency. We know that without the normal pancreatic enzyme, nutrients will not be properly absorbed. So another problem associated with this disease is malabsorption. If the endocrine function of the pancreas is affected, the patient will have diabetes mellitus. So malabsorption, malnutrition, and peptic ulcer disease are some of the complications that are associated with this chronic pancreatitis. We also see that because there's so much pain, these patients are at risk for having narcotic addiction. And chronic pancreatitis increases the patient's risk for having pancreatic cancer. So let's go to our assessment finding and see what we'll have. The patient is going to be complaining of recurrent left upper quadrant abdominal pain that radiates to the back. There will be anorexia, nausea and vomiting, weight loss, then flatulence, constipation, steatorrhea. That is the fatty, frothy smelling stool. It's very fatty, it's bulky, and it's smelly. When we do the labs, we'll see increased serum amylase and lipase. There's going to be hyperglycemia. There's going to be jaundice, ascites, muscle wasting. Muscle wasting is also there. These patients are at risk for respiratory compromise, and that will be when we listen to the lungs, you begin to hear these adventitious or diminished breath sounds. You may also see the patient is dyspneic or having orthopnea. C-reactive protein too will also be elevated. So what is our nursing intervention? We have to teach the clients to avoid eating heavy meals. So light meals, instruct them about the importance of stopping alcohol. They should also avoid caffeinated beverages. We know that one also puts them at risk for having this peptic ulcer disease. Instruct the clients in the prescribed dietary measures, how they are supposed to limit the fat and protein intake. So low fat, low protein diet is what we expect for these clients. We give them supplemental minerals and vitamins to increase their caloric intake and give them pancreatic enzymes to help in digestion and absorption of the fat and protein. Then, we say they are at risk for having DM. So for that, we are going to give them hypoglycemics, which may be in oral forms, like the glyburide and all that. Or we give them insulin. We give them insulin as prescribed to manage the diabetes. We teach them also on the treatment plan, that is the schedule for this insulin treatment. As well as we tell them that if they notice that they are having worsening steatorrhea, worsening abdominal distension or cramping, or they have skin breakdown, they need to report the HCP. So they report the HCP findings: steatorrhea, abdominal distension or cramping, as well as skin breakdown that can lead to pressure injury developing. We instruct the client to restrict activity to one floor until their strength is regained. These are the patients we put on bed rest. We want them to relax, and then we don't want them to do too much. Diagnostic tests that we are going to be doing for these clients include CT scan. The CT scan will help us visualize the size of the pancreas. Also look at the fluid collection, the abscess. We talked about it when we talked about the pathophysiology in the previous review, so you can check that out. We look at abscess, from the abscess, check the mass. You look at the mass because there will be a palpable mass, and then this CT will help us diagnose areas of hemorrhage or necrosis. They also do the abdominal x-ray and ultrasound. Chest x-ray will identify pleural effusion to see if the pleural cavity is affected. And there can be pleural effusion caused by enzymatic irritation from the leaking pancreatic fluid. As the enzymes are leaking, it can now go in there and cause more problems. So that is for that. If you still want me to go over, okay, let's just do a recap of what we talked about in acute pancreatitis in terms of our nursing assessments. We should check them for acute epigastric pain, which is steady and severe, that occurs in the umbilical area and radiates to the back. We said that is because of the retroperitoneal location of the pancreas, and it may be temporarily associated with ingestion of alcohol or due to a fatty meal. The pain these patients have is worse when they lie down in a supine position, but it improves when they sit up and lean forward, or they flex their knee and stay in this fetal positioning, the one we used to talk about, fetal positioning. Nausea and vomiting is common with these clients, and it gets worse when they take something, when they eat food. These are the patients where you see some Q banks will give you case scenario and they'll say vomiting does not relieve abdominal pain. Yes, the vomiting these patients have doesn't make them feel better. They don't vomit and feel better. The abdominal pain is still there. In terms of vital sign, we said they have low-grade fever, and that's we should take note of. Is an Nclex typo. You see it in some Q banks. The temperature is rarely above 102 degrees Fahrenheit. That is 38.9 degrees Celsius. So it doesn't go so high. They have this kind of low-grade fever. And then we see hypotension in their vitals and then tachycardia. So that's giving signs of shock. Leukocytosis, that's for their labs. We'll see high levels of WBC. There's hyperglycemia. And this hyperglycemia we are talking about is that it gets as high as 500 to 900 milligram per DL. Please, let's take notes. The amylase we are talking about can be elevated for 48 hours. 48 hours elevation of amylase. And then for lipase, there is increased urinary amylase. We've talked about that. Abdominal tenderness, rigidity, progressive distension, and decreased bowel sound is there. We've talked about the cooling sign and gray area, which is the Turner sign that is over the flank. Then if the disease is the fulminant type, it will progress to hypovolemic shock, ascites, jaundice, and then renal failure. Other labs we are going to see is hypocalcemia, because if the calcium is sequestered by fat necrosis in the abdomen, we will begin to see this hypocalcemia. Then there's elevated C-reactive protein, hypomagnesemia. The magnesium level is low. Hypoalbuminemia, the albumin level is low, and that contributes to the hypovolemic shock. Liver function tests too will be affected if the liver has been involved. We've talked about the pharmacological management of this condition, where we mentioned the proton pump inhibitors, omeprazole, H2 receptor antagonist, the ranitidine, famotidine. We talked about the use of morphine for the management of this whole thing. Then total parenteral nutrition can be used. I also want us to talk about the pancreatic enzyme replacements, the pancrealipase. This one comes up in Q Bank where you're solving your question bank. You may see it. So let's talk about it. Let's study about it. So the pancrealipase is used to supplement or replace pancreatic enzymes and thus improve nutritional status and reduce the amount of fatty stools these patients have. A deficiency of pancreatic enzyme can compromise digestion, especially the breakdown of fat. So the patient needs to take the pancrealipase with all their meals, whatever they are taking, any meal, any snack, so that it can go there and digest and metabolize it. The side and adverse effect of pancrealipase includes abdominal cramping. Patient can have pain, nausea, and vomiting, as well as diarrhea. Products that contain calcium carbonate, magnesium hydroxide, those ones, they interfere with the action of the pancrealipase, because you know that hypermagnesium still hypercalcemia, sorry, that's what I want to say. Too much calcium, we have already mentioned it as part of the problem of these clients. So we have to avoid any medication that contains calcium containing medication. We need to avoid it for these clients. Then for magnesium, we say they have hypomagnesemia, and we also want to avoid magnesium hydroxide because it interferes with the pancreatic lipase enzyme. Follow for more and see you in the next study session. Happy reading.